I hope you guys enjoyed today's episode, and we will be paying attention to your questions and your comments. Have a lovely episode. Bye.
Bye.
Hey, Rada.
Hi, Lina. How are you?
All good. Hello, everyone.
Hi, everyone. Hope you're doing well. Welcome to Lina and Rada's show.
Welcome to another episode. And as you guys can see, this is a recorded episode because currently we are under stage 4 restrictions in Victoria. So basically, we cannot meet. So I'm with you in spirit, Rada.
Yeah. Go, Victoria.
Hopefully, we can overcome this soon enough because I think a stage 4 is a little tough, don't you think, Rada?
Yeah, exactly. Don't tell me, please. I prefer to forget.
I know.
Yeah,
I
it's
know.
not an easy time for anyone, but we still have to stay positive. Today, when I woke up, I saw these terrible images in Lebanon, and this makes you feel like a bit more humble and not complaining too much.
True.
A small word for these people, for the people of Lebanon and the families there, that our hearts are with you. It's
True.
terrible. It's
very sad.
Yeah, it is. So we hope everyone is safe. If we hope you don't have any member of the family there. So yeah.
Yeah, we don't know at which stage are you guys going to watch this particular episode, but as Rada said, today, this day that we are recording the show, everything that happened in Lebanon. So that's why all our prayers are with everyone over there that has been affected by this.
Okay, so today you're
on a lighter note. Yeah. What are we going to do today, Rada?
The old TG vs new TG. We're happy to continue this adventure with you, and hope you found the last sessions beneficial, and that it helped you understand a bit more and help you in your revision and your exam management as well.
Okay, I mean, I think that by this point in time, probably you guys have watched a couple of recorded episodes of the show. It's very tricky to follow the timeline, but if that's the case, remember, you can leave your comments on the comment boxes, all your questions, and so we can, at the end of the episode, get together with you guys and try to clear any queries or doubts that you may have. So feel free to give us, thumbs up and put your questions over there that we are happy to answer.
Yes, so today what we are going to talk about, Lina?
Well, today we are going to have the dental management of patients with medical conditions, new chapter in the new TG. So basically we will try to tell you briefly which changes did we spot in this particular chapter, so you can be aware of that. Yeah, I mean, I think we cannot stress enough that you guys need to go there, read very careful the TG, analyze it very well. I mean, don't take our word for it.
Go into details. Yeah, exactly. Do your own study.
True, because in this quick overview that we try to do on the episodes, it's quick. So it's not very thorough, very comprehensive. It's just to give you guys an idea. And then you can go back there and try to analyze every single thing by yourself, which is, I think, the most important thing to do.
Exactly. So let's start.
Okay, let's do this. What do we have first, Rada?
So firstly, we are going to talk about antithrombotic drugs, which took us a lot of time because many changes, many new informations mainly. So what we could say in the beginning is that something is very important is first you need to understand what type of medication the patient is taking. Is it first an anticoagulant, an antiplatelet? How many medication that is affecting the bleeding? So we are going to talk about that a bit in more detail just in a few minutes, but whether the patient is taking one medication, two, three, multiple, it's going to affect your management and how you're going to treat your patient. So this is the first detail and information that you need to know in order to manage in a better way your patient.
Yeah, definitely, completely agree. I think what you see at first in the beginning of the chapter is what Rada just said, you know, a brief description of the antithrombotic drugs with some names, which I think is important for you to memorize, even though we have told you guys you don't have to memorize everything, you know, because if we are taking this to an OSCE scenario, you are going to be able to have during your 3 minutes time, you know, take a look to the memes just to establish which type of medication. Obviously, if the name is common enough for you to remember, like apixaban, rivaroxaban, warfarin, we are very used to those names. If the name is common enough, you will save some time, obviously. But if the name is not as common, then you need to refer to your memes just to establish if this is an anticoagulant drug or an antiplatelet drug, if it is oral or injectable. So I think that will be the first time. And if you go to the following page, which is 154, that bold title that you have there is about how you perform the risk assessment for patients taking antithrombotic drugs and undergoing an oral dental procedure. So these things that you see here under this title are the first 4 things that you need to do. So Rada just mentioned the first one, the properties of the antithrombotic drug.
You also have to gather more information if it's not given, in which category your patient falls. Is he in a high risk of bleeding more than usual or not? So you have box 18, page 156. You have several conditions that can make the patient more likely to bleed even more in combination with this medication. So for instance, if the patient has high blood pressure or older age or hazardous alcohol consumption, which means more than usual. If the patient has a history of stroke, all these conditions, on top of this, the medication they are taking will make them more likely to bleed even more than if they had only this medication. So this also will change your management.
Yep, definitely. And we were discussing this morning, Rada, because we see throughout TG a lot the term older age.
Oh yes.
Frailty. So we were wondering what do we consider elderly here in Australia? So according to our readings, it's someone 65 years old or more, correct? So basically that's what is considered elderly patient here in Australia. That doesn't mean that every single 65-year-old patient is the same, because we know that there's people at 65, they are going through a lot of medications, a lot of diseases, and that changed the entire view. And there are 65-year-old people that are completely sound, you know, very healthy, no medications, no pre-existing conditions. So you need to take that in account. But if you were wondering, what do we consider elderly in Australia, is 65 years old or more.
Exactly. So that's the second point that you have to understand and get the information in order to manage in a best way your patient. Then they added table 16, the following page. They said and they're giving you details on what is a procedure that is at risk, lower risk or higher risk of prolonged bleeding. So this notion is very important, again, because of the management of your patient. So if the patient, for instance, is having a procedure in a lower risk, like here, let's say extraction of a small number of teeth, okay? If the patient is only having one anticoagulant, so one drug, it will not be a high risk case of prolonged bleeding. But if the patient is at high risk of prolonged bleeding with a procedure, let's say a biopsy, a flap surgery, or an extraction of a large number of teeth, plus multiple medication, antithrombotic medication, then he will fall into a patient at risk, and you will manage this patient differently from the first example. What do you think, Lina?
Yes, no, this one is quite important. So as you can see, guys, from the things that you need to assess, we have first the type of medication, then we have any patient-related bleeding risk factors, and then we are going to classify our procedure. So you go to that table and you establish if that procedure is likely to cause a lot of bleeding or not so much bleeding or not bleeding at all. That's the first procedure that you have over there. So I think you need to establish that pretty well, because I think in this new TG, they are trying to give you more information for you to develop your own criteria on how to address things. So having said that, any particular case is not the same for any other approach. What I mean is, we cannot tell you guys, if you get a patient that is on aspirin, this is what you need to do, because it's going to be related to all the things that we are discussing right now. So you need to take every approach on the basis of every single case. Because if you try to go for a cookbook approach, that sometimes people try to look for, like, just tell me what should I say and that's it. But that's not that easy. It's about you putting out there your own criteria, and this new TG is giving you the roadmap, you know, for every single thing, including these antithrombotic drugs.
Yeah, totally agree. So then they are giving you a map how to manage locally your patient if you can manage him locally. So we used to have in the old TG a table about quite only warfarin management, and just for the rest of the medication, just suture, local, quickly, they said quickly, like cellulose or collagen. But now they are giving you a bit more into details. They have lightened the information given for tranexamic acid mouthwash. Again, it's only for warfarin, but according to new TG, we don't have to rinse with the socket, inside the socket with the tranexamic acid, and all this stuff with it. It's just you have to rinse, to ask the patient to rinse before, or you apply topically, which is the best. And you give the patient the tranexamic acid mouthwash that he's going to use for 2 days, and how to use it, the dose and all that, and then you will follow up the patient. It's a bit more simple, I guess, with this table.
Yeah, I think so, yeah. This table is quite important, even though it's simpler. You need to see in this table the importance of doing the risk assessment that we spoke earlier. Because if you establish the medication, then you know that if the patient is taking warfarin, then you can apply the tranexamic acid protocol. But if the patient is on non-vitamin K antagonist or even antiplatelet drugs, there's no purpose of doing or using the tranexamic acid, which is a discussion that has been lengthy because a lot of people said that they don't care, even though it is robidoxaban or epixaban or even warfarin, they're going to go for the tranexamic acid, which I don't think is going to harm anyone, honestly, but it's not going to help either. It's only going to help during those patients that are taking the warfarin. So in this particular box, 19 box, definitely you need to take in account that the medication is going to dictate the protocol that you are going to follow with this patient. Having said that as well, INR is only useful for warfarin. It's not useful for non-vitamin K antagonists. So that's another thing that you need to digest, because for, you know, most of us that we have been, or we gave the exam when OTG was in place, for us, you know, it was like a mantra, you know, everything about the INR, everything about the protocol of tranexamic acid. And now we need to forget that and to learn new things. So I think that's going to be important for cases.
But again, they're saying that in patients that are taking non-vitamin K antagonist, anticoagulant, there is no evidence on the use of tranexamic mouthwash. So because it's not the same like mechanism, so it's not useful. So only for warfarin you can use the tranexamic acid mouthwash, and the rest is just all the local management, like apply pressure on the wounds, minimizing the tissue trauma, placing cellulose and collagen, suture, and following up. So yeah, I wouldn't advise or recommend you to use the tranexamic acid mouthwash in the other case than warfarin.
Yeah, completely agree with that. So it's very important for you guys to go back to these pages, read it, analyze it, and establish if this is going to be applicable for any particular case that you have on OSCE. Okay.
Yes, so just after they are talking about the patient and the medication. So depending on the number of antithrombotic drugs the patient is taking, your management will be different. Basically, what we can summarize is that if the patient is taking 3 of these medications or 2, then you need to refer the patient, especially if the patient has a higher risk of prolonged bleeding based on table 16. The INR also changed. In the old TG, we could manage up from 2.4 to 4 with tranexamic acid mouthwash. They have changed the values. If the INR is 3.5 or less, you can perform the procedure. If it's more than 3.5, you refer the patient for medical assessment and stabilization of the INR. Or if it's an emergency, of course, you will refer to hospital.
Yeah, which is another change, because in OTG, it was up until 4 that you consider that you could intervene the patient. But here they're saying 3.5 is the limit. If anything is beyond that, then it will be better just to reassess the patient, or even, you know, refer for the physician.
Yeah. Then they are talking about the one oral anticoagulant or a dual antiplatelet therapy.
Mm-hmm.
So again, depending if the patient is at lower risk of bleeding, no other factors that could increase the risk of the bleeding of the patient, again, you refer to box 18. Then you can use all the local measures, box 19, and you can manage. But other than that, if you have other factors, procedures that are at higher risk of prolonged bleeding, then you need to refer.
Yeah, definitely. So when you read all these classifications, then you know, see that everything takes you back to the risk assessment. If you are not clear on that, then it is very difficult for you to establish the management. And that's what you guys need to remember when you are doing the OSCE communication station. It's not about if what I'm saying is right or wrong, is how do I explain my thinking process to the examiner, so-called patient in this case, in very, you know, simple terms, and I'm doing it correctly, that will be okay. But remember, there's no tricks to it. You know, it's just reading and studying, and that's pretty much it.
No, you have to develop your critical thinking. You have to identify the flags that, when combined together, it will give you the correct management. Okay, a type of medication, I have this, the patient, what is his other risk factors, okay, I have this and that. What is the procedure? And with already these three, I know if I can manage myself or if I am going to refer the patient. It's something that you have to develop automatically.
Exactly. That needs to be in your brain, you know, it has to be very fast the moment you see that case on that screen. Because you are going to have 2 minutes reading time, but you need to be able to be trained already in this critical thinking process, because if you are thinking that you are going to get there and then decide what you're going to do, it's not as simple as that. You need to first train your mind, and that's why you need to rehearse OSCE so many times, you know, like I did, like Rada did as well, because you need to train your brain, you know, into thinking fast, into be able to be efficient and to be able to deliver that information in that time frame that I know is small, but believe me, you know, you can do it if you train properly.
And also try to modify each time the details of the scenario with your study partner, for instance.
Yep.
Not all the time rehearse the same scenario. If you just give the same details all the time, you're not going to have this automatism to say, okay, I have this situation, tac, 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 mentally, and then tac, I give the management.
Yep.
If you just repeat like a parrot, it's not going to work.
Yeah.
Develop your critical thinking in order to have it. It will be automatic. You will not need much time, because 3 minutes to prepare, yes, it is okay, but the OSCE will not only about this particular information or management. You will have other information that you will need to manage as well with the patient, with the examiner. Rarely you have, of course, some OSCEs that they are straightforward, but you have some OSCEs that you have complex and multiple information that you have to deal with.
You need to spin a little bit your cases, otherwise then you're going to memorize things, and that's not going to be useful for you during your exam.
Yeah, totally agree with Lina. So yeah, you go through all these patient management. They're really detailed how you're going to manage depending on which procedure, which medication, how many of them. So you have several pages. So just go do your homework and you'll be fine. I think that's it with the bleeding problems.
Yeah. And then corticosteroids.
Yeah. So few changes with corticosteroids. The first one is that for corticosteroids, you needed in TG to let your patient under supervision for 24 hours. In a new TG, it's not only that, so you need to supervise for 1 day, but also the carer, so the one who is supervising the patient, needs to keep in touch, to stay in contact with the patient for 2 to 3 more days. So this is very important. Another thing is that they divided the dental procedure into non-invasive, invasive but less than 1 hour, and invasive more than 1 hour. So depending on that, you will manage differently the patient. So if it's, so first, again, you have to understand what is an invasive procedure, what is non-invasive. So for instance, non-invasive, they classified the dental check, x-rays, impression, that are the non-invasive. And the invasive, they added restorative work, scaling. So we could think that, wow, scaling, even me was surprised. But yes, of course, extraction, periodontal treatment, implant. So it looks like not only stressful procedures like we learned with the OTG, but also any procedure that you will use instruments like dental checkup. Okay, you're just going to use a mirror and your probe and your explorer, x-ray, but anything else, it's considered as invasive. And then you have less than 1 hour, then the patient will increase the dose of his corticosteroid. So again, not you doing that, but the patient should seek his medical practitioner advice. And if it's more than 1 hour, and it also includes the GA or any sedation or fasting as well, then you need to refer the patient for the treatment. So you can't treat this patient.
Yeah, definitely. So basically the change here is what they classified as an stressful procedure, because like Rara said, we were quite surprised that considering a professional clean, you know, something that that you need to change the dose of the corticosteroid. So apparently you need to do that. Again, this is for the purpose of the OSCE. Sometimes we see in real life that that's not necessarily the case. But for the purpose of OSCEs, and I think that's one of the tricky things to overcome when you are practicing for OSCEs, because since we are so used to practice by ourselves, you know, we were students quite a few time ago, and when you are like, but wait, I don't do that in real life. And yes, some of you are going to have some contradictions in there from what you are doing in your daily practices. But again, for the purpose of the OSCE, for the purpose of the exam, you need to adhere to these particular guidelines. So it's quite important for you guys to not to fight it. You know, some people fight it. Like, I'm not agreeing. I mean, it doesn't matter.
Just for the sake of passing ADC, just let it go, learn what they want. And then when you'll be in your practice in Australia, then you do whatever you want to do.
Yeah, I'm not saying that this is not going to be the case. I was talking to Rada that I think it was for me yesterday. I had a patient which is taking a lot of medications, including corticosteroids, and the GP suggested me to speak with the endocrinologist, and the GP spoke with the endocrinologist. So there are going to be a few cases that are quite special that you know that you need to put in practice this. And if you already know it because you have successfully passed your exams, that's going to be very handy for you.
All right, so next change is with the medication related osteonecrosis of the jaw, so MRONJ. What you can tell us, Lina, about this?
Well,
I think there are a lot to say.
Yeah, at first glance, the terminology is different. when you read OTG, they are talking about bisphosphonate related osteonecrosis of the jaw, because they were suggesting back then that only the bisphosphonates could create this kind of presentation. Now the term is medication related osteonecrosis of the jaw. So we are not using any more MRONJ because it's not just related to bisphosphonate. Because they are including here also the denosumab, which is not a bisphosphonate, but is used to treat osteoporosis as well. So that's why these medication also have the risk of cause medication-related osteonecrosis of the jaw. So at first glance, the terminology is going to be different. Therefore, you need to adapt your speech to that, you know? Yeah. And we already have talked about that if we need to forget things and just to learn new things, well, we have to do it. And after that, in table 17, they have described very comprehensively all the stages that you can see of necrosis of the jaw. Because before they were talking about the stage 0 and basically jumped to a stage 3. Now they are telling you there's a stage 0, 1, 2, and 3, and which ones are those characteristics in there. Which I think is not that they are going to give you a picture on the OSCEs and you are going to say, oh yes, you are on stage 3 or 2. That's not the case. But remember, if you have some features and if you are seeing something that it could look like osteonecrosis of the jaw, you are going to ask some questions, and those features basically open the door for you to ask the correct questions. Okay, what else, Rada?
CTX.
Yep.
Not reliable anymore, so they don't recommend to use it because it depends on many other factors. So even the sex of the patient,
the age, we already
the
talked about.
age, yep. The medical condition associated. If the patient, the woman is in a menopausal status, anything related to hormones, so for them it's not reliable anymore, so they don't advise us to, it's difficult to know whether it is the patient is at risk or not with these values. Also, they're saying that the patients that are female and older than 65, already they are more at risk of having this kind of condition.
Yes, but remember that in the OTG, even for CTX, they used to give you a table, you know, with all the values and how do you establish the. Here, they don't even bother with that because, as Rada said, it's very tricky to rely only on the CTX test. So definitely that's not something that you need to take in mind. But then you go to figure 6, which is page 168, which I think is quite useful because, again, they are giving you a roadmap to develop your criteria and how you are going to manage these patients. So basically here, they take every single question that we should ask to the patient regarding these medications. And depending on the answer, yes or no, this roadmap is going to take you to a particular management. So again, it's about asking the correct questions, getting the answers, and start establishing what your management is going to be.
Yeah, exactly. And yeah, it's straightforward with the management table. But one thing that caught our attention is that we no longer recommend any drug holiday. Like in TG, it was like 10 days, some days before, then we can restart 10 days after, something like that. But no, it's no longer the case. So you just have to follow these good figures. It's easy to understand and to follow if the patient is taking medication related to cancer or not. If yes, what shall I do? If no, how long the patient has been taking this medication, and so on. And then you will reach the management of this patient.
Yeah. So again, the suggestion that we did earlier, that we gave you earlier, try to rehearse the cases with all possible alternatives. So if you know that you have a denosumab case that I think we had in the armamentarium of the old OSCEs, remember that case that the patient is taking denosumab and warfarin and, you know, some periodontal abscess or something like that. So try to rehearse that case with different outcomes. So ask the questions. Sometimes you are going to rehearse that case saying yes or no to a particular questions, and you can start developing that critical thinking so you can end up with a good reasoning for the management of the patient.
Exactly. They also give you in box 21 how to manage this patient that are at risk when you are going to undertake any bone invasive procedure. So they are giving you advices like not using antibiotic prophylaxis, minimize the bacterial load, for instance, mouthwash before and after. It was not in TG, but it was written, as far as I remember, in the DVHS,
yeah, the guidelines,
the Victorian guidelines. So yeah, they are taking this into account, and they put it on in a table here, page 171.
Yeah, and I think in those guidelines, they were already saying that CTX was not reliable, because I think those guidelines were more current than the old version of TG. So some people used to have a conflict with that. They were saying like, oh, the guideline says this and TG says that, but you know, as long as we—
Now it's clear.
Exactly. Now it's completely matching, because I think the old TG was not current enough for this particular management. Okay, and then following the chapter, bleeding disorders, adrenal, thyroid, I think all of that is pretty much the same. Included elevated blood pressure. They have added here cardiac implanted electronic devices, like a small title over there, but basically it says that if the patient has a pacemaker, that doesn't make any difference for us. So I think that's not very something that we need to stop and discuss too much. And then we go into diabetes. And in diabetes, we do have some important changes there, right, Rada?
Yeah, exactly. So they're saying, first of all, that poorly controlled diabetes, even though the patient has a post-procedural complication, like an infection, the antibiotics prophylaxis is not longer recommended. So something else that it is saying, I think it's the other page, I'm not sure, no, it's this one. So yeah, even if they have the diabetes, poorly controlled diabetes, it lowers the immune system. We consider them as immunocompromised. We don't give them antibiotic prophylaxis. This is something that is quite interesting and quite new. They added some information about a medication, the SGLT2. So this was not the case in the OTG. So they're saying this patient, they are at risk, more at risk of ketoacidosis condition if they are fasting or very restricted dietary intake. If they are undergoing a surgical procedure, which could be the case with us, or have an active infection, also if they are dehydrated, but this medication need to be stopped before the procedure, and we need to consult again always with the medical practitioner.
Correct. Yeah, so I think these new type of medications, and they are giving you their examples of the name of the medication. So that's another thing that you would like to, you know, just read and reread in order for you to remember those names quite fast. And there's something here that was mentioned on the OTG, and it was about the percentages of the test that they don't mention here. They are not very strict about those values. So I think it pretty much, you can rely on the information that the patient gives you, apparently.
Mm-hmm. Or if you don't know, you just consult with the GP. It's something they will never mark you down. Or it's the opposite. They will think, oh, this practitioner, this dentist is careful and is not jumping into any treatment or management. It's the opposite. They will think you're safe. So if you don't know, if the patient seems to not know, just say, okay, that's okay. I'm going to consult with your GP if you agree, and we'll go from there. That's it.
Exactly. I think better to be safe, as long as being safe is on the basis that you are explaining very well to the examiner why are you taking that path. It's not that I have a patient that has a medication and just to make me look good, I'm going to refer you to the GP. No. It's not about that. But some complicated cases, when you refer to the GP, when you speak with the physician, that's going to be actually good for you. So I think that's quite important to have in account.
Okay, about the immune compromised patient, it was actually 182. When they said that a poorly controlled diabetes can compromise the immune system, but it's not an indication for surgical antibiotic prophylaxis. So I jumped the pages, but here you have the information. Other than that, I think it's
pretty much the same.
Yeah, they give you more information about which patient is more immunocompromised, depending on his condition or the medication he's taking. The rest is quite similar. We noticed in the psychological and psychiatric disorders, there is no longer, lucky for you, the table with all the name of the medication. So you don't have to learn that, which is great. Do you remember, Lina, when we had to learn?
Yeah, because for the psychiatric disorders, they gave you that table on TG, which was very extensive with all the names of the possible medications. But I think here they are not focusing too much on that. Again, because I think if you have the memes, you can just consult it during the 3-minute reading time. And obviously there's going to be some psychiatric drugs that are very, very common that you guys probably are already familiar with. So there's no need to memorize anything that's not basically very common.
Other than that,
that's pretty much
quite similar, the rest of the chapter.
Yeah. So in order to summarize for you guys, things that you need, I mean, we're not saying that you don't need to read the rest of the chapter. We're not saying that.
No, you need to. You have to do your homework.
Just to clarify, you guys know that every single page of TG, you need to, know it by heart, ideally. But just to summarize for you, a lot of changes regarding antithrombotic therapy. So you guys really, really need to go back to there and try to read. Some changes regarding corticosteroids, which are not very extensive, but they are significant in the terms of how you are going to apply this. Terminology changes regarding osteonecrosis of the jaw, with very important changes regarding management. Go back to that and try to take a look to that. And also regarding diabetes, some changes, especially in that new medications that they call glucose cotransporter inhibitors. So you would like to know what is that. And I think that's pretty much the most relevant things that we are seeing in there. Again, that doesn't mean that you don't need to read the rest of the chapter. You need to do it and need to do it very thoroughly. Basically, what Rada and I were trying to do here is just to discuss with you what changes, you know, spot the changes, but definitely the application and how thorough and comprehensive you are when you are doing your reading is very important.
Yeah, of course. It relies on you only. I mean,
yep.
Only you can do your homework and this thorough study of the new TG. We can't do it for you guys.
Yeah, and I think we already know by now that there are no shortcuts for these guys.
Yeah.
Study, reading, rehearsing, that's quite important. Look for a study partner just for you guys to rehearse a lot. If you don't have a study partner, or you will have to like a more, as you know, for a lack of a better word, a more professional help, we have here at Dental 101 some OSCE 101 sessions, something that we call OSCE Body. People use it quite often. That's also available for you. And I think, and it's not only here, I think you have a variety of options, you know, to choose from. But all those options rely on you guys doing your study and your homework at home.
If you don't know your basic, I mean, it would be very difficult for you to have all this critical thinking, to even, as I said, they don't want parrots, they want dentists. So it's upon you to do that. Few months and you pass, guys.
Yeah. I think Rada and I repeat that a lot.
Yeah.
You know, sorry if we're repetitive, but that's the reality of it.
But because we've done it ourselves. It's not like okay, we are a bit fantastic, but I'm kidding. But it's not because we are genius or whatever. I'm thinking about myself.
Yeah, true.
I'm not a genius or anything. I just studied hard, very hard, and yeah, that's how I get my ADC certificate.
Correct. Yeah, completely agree with Rada. It's not about that we have any, you know, uncommon
superpower
gift or anything like that. It's just about hard work and a study. And again, guys, please leave your questions on the comment box, because most likely we'll be watching this episode with you when the time comes, and we can answer the questions, you know, in a Q&A live session or something like that we are thinking about doing. So I think that's pretty much it. Anything else that you want to add, Rada?
Yeah, I think we've gone through all of this chapter, the advices for how to study and all that. So just keep going and practice.
Yeah, and yeah, I think this episode was quite a long one. We tried to keep it short, but we knew that this chapter was going to be chunky in some places. But hopefully this has been helpful for you guys, and we will see you in another episode of Lina and Rada Show.
Rada Show. Bye-bye.